So my topic is, do all patients with intraocular tuberculosis require co-administration of oral corticosteroids along with ATT? I don't think so, and I will be speaking against this. At the outset, I'd like to acknowledge the Aios ARC for this opportunity and the team members of the Uvea team at Narayan Nethralaya and all my teachers. So tuberculosis has been a leading global cause of mortality, and there has been difficulties in its eradication. This has also led to continuous surge of extrapulmonary tuberculosis, of which ocular tuberculosis causes significant morbidity. However, we still have paucity of data to help us have treatment guidelines, and it continues the enigma of the management of this disease. The objectives of my presentation are to discuss why we need to use corticosteroids in tuberculosis and what are the concerns, so why not to use it, a few examples of ATT monotherapy, and also review of literature to support the same. And finally, I hope I will be able to coax the role of ATT monotherapy in the treatment of intraocular tuberculosis. So as in any infection, the treatment is directed towards the parasite. Similarly, in tuberculosis, we need to treat with ATT. But then why do we need a host-directed therapy or the corticosteroids? This prospect came in when people understood that there may be a pathological aberrant immunity of the host to the Mycobacterium tuberculosis that could cause a different or a variety of phenotypic presentations. So we could have the prospect of host-directed therapy that would not only augment the immunity, but also facilitate the bacterial clearance. So corticosteroids is not used in all the forms of tuberculosis in the body. In fact, it is there in the treatment guidelines of only some of the manifestations, while it is contraindicated in others. So the role of corticosteroids, as we understand, I'm trying to correlate it systemically, is given for life-threatening conditions when there is a fear of compressive effect on the vital organs due to the inflammatory edema, or prolonged inflammation can lead to sequelae formation like strictures and adhesions, or when there's a risk of paradoxical worsening. Similarly, where it is contraindicated, it is because of fear of risk of treatment failure, risk of relapse, the adverse effects of steroids, and the risk of opportunistic infections and cancers, especially in immunosuppressed individuals. Coming to ocular tuberculosis, the CORT study found varied use of adjunctive therapy or a combined therapy for ocular tuberculosis. While in Asia, more than 80% practitioners used a combined therapy, in the West, it was only about 60%. This may be attributed to the uncertainty of the diagnosis, the different genotypes of the individuals in different geographic locations, and the varied phenotypic presentations of ocular tuberculosis. There are these known adverse effects of corticosteroids, be it ocular or systemic. Then again, there is a risk of failure of ATT when treated with corticosteroids, because the isoniazid concentration is reduced by the use of prednisolone. This is because of enhanced rate of acetylation and also increased renal clearance. At the same time, rifampicin can increase steroid metabolism by inducing liver enzymes. So this may change the levels of the ATT in the blood. And finally, there is a risk of relapse by inducing latency of tuberculosis. So next we come to the topic of ATT monotherapy. So if we don't give corticosteroids, will ATT monotherapy work in patients with ocular tuberculosis? Yes, it can work because there is evidence of role of direct and microbial infection in ocular tuberculosis. Then here we must also acknowledge the inherent anti-inflammatory properties of rifampicin. There is lack of evidence of beneficial effect of combined therapy in literature. And some reports also suggest that corticosteroid therapy, particularly when started prior to ATT, have resulted in poorer final outcomes. So if we consider the CORT study, which strongly recommends adjunctive therapy, the meta-analysis which shows that ultimately there is no influence on final outcomes, some of our personal experience and other reports, we will understand that certain forms of ocular tuberculosis can respond to ATT monotherapy alone. So this is one patient of a 28-year-old male who had decrease in vision in the right eye since 1 month. He was positive on Montu and chest imaging. He had a solitary choroidal granuloma, which responded to DOTS regimen and resolved with minimal scarring. If that was a small lesion, this is a larger, almost a 4 disc diameter lesion, It was a large choroidal granuloma with a subretinal abscess, which was treated with ATT alone for 9 months and resolved with minimal scarring. So is this only us, or are other people also finding these? So anti-TB monotherapy was studied for choroidal tuberculomas in this observational study, where two groups, one of monotherapy and one of combination therapy, were assessed. And interestingly, they found that anti-TB monotherapy is sufficient for the treatment of choroidal tuberculoma, and monotherapy can lead to faster resolution without compromising visual outcomes. Yeah, so the next is for isolated tubercular retinal vasculitis. This was a larger study of 50 eyes, where they took comparable cases of retinal vasculitis, and they found that ATT monotherapy had no influence on resolution, healing pattern, or vaso-occlusive complications. So what does the future look like? We are moving from a conventional treatment to contemporary treatment. Now we have these highly vascular TB granulomas, which benefit from local anti-VEGF therapy, though for now it is combined with systemic immunosuppression, but I don't think we are far from the days when we might be giving intravitreal ATT and anti-VEGF for only ocular tuberculosis without any active systemic infection. So which phenotypes of ocular tuberculosis need co-administration of corticosteroids is still not, this topic is under research and there are no clear-cut guidelines. But if I draw the corollary from the systemic use of corticosteroids and our experience, we understand that oral corticosteroids are required only in select cases where there is sight-threatening conditions with juxtafoveal or juxtapapillary lesions, where there is optic disc involvement, vitritis more than 2+, or case of paradoxical worsening. Only these cases we need to give oral corticosteroids to avoid the risk of unnecessary use. So all patients with intraocular tuberculosis do not require co-administration of oral corticosteroids with ATT. To summarize, we still have unclear pathomechanisms of different phenotypes of ocular tuberculosis. There is no conclusive evidence yet of the benefit of using the adjunctive role of corticosteroids. However, we run the risk of corticosteroid-induced adverse effects. Guidelines that we follow cannot be all inclusive, and we need to watch out on case-by-case basis with respect to inflammatory signs and sight-threatening lesions. Yeah, thank you.
That was a lovely talk, Dr. Sai Bhakti, and very informative. So let me just take my question a little differently and more basic. So if you are, Dr. Avinash, I'm going to ask you that question. If you are going to start oral steroids with anti-tuberculosis treatment, what would be the time gap before when you would decide to start oral steroids? And is there one single test to diagnose tuberculosis before we start medication? Does Mantoux have a role? I want to answer for all the questions.
There are 3 questions.
Tiny answers.
Yeah. So in terms of, in the world of the treatment for infectious disease, people are always divided whether to start corticosteroids in the management of infections. So that debate would always continue whether to start or not to start. And that's how both the speakers have put forth their points in a very beautiful way. Now, having understood that, that this debate is going to continue, like Sai and Sharanya both brought out that there would be an element of an hypersensitivity reactions which do happen in these cases, where the role of corticosteroids would be there in these cases. So, what are those cases where hypersensitivity reactions would be there, and I would use corticosteroids in my practice? I would say 3 important conditions. One is if they present with a morphological pattern of serpeginoid-like choroidopathy, and second, if there is a paradoxical worsening, and in third condition, if it's associated with retinal vasculitis. So these are 3 indications where I'm extremely clear, and also where I'm extremely clear where I would reserve the steroids, where I would start on ATT would be the unifocal choroiditis and associated with subretinal abscess. There I'm extremely clear I would be starting with ATT, though if it is even very close to the fovea, I want to see some sort of response happening. Then it's fine then in extensive spread and going in for certain cases like a panophthalmitis, which can happen. Now, that would answer the first question. And the second one, when would I start if I have to start? So in the first case where those 3 indications, what I mentioned, the serpeginoid-like choroidopathy, I would start simultaneously along with anti-tuberculosis treatment. and even in paradoxical reaction where you would amount to increasing the steroids than conventionally what the patient is on, and hypersensitivity reaction, which is vasculitis, I would start concomitantly with the ATT. So, and the third question was?
Would you, is there one single test for?
Single test. So, single test, I would put test, yes. I primarily rely on MAN2 is the one which is for systemic investigation, but clinical features of 3 important signs which I've elucidated before, which is something which I'll go behind to make a diagnosis, the posterior segment manifestations. So clinical signs first and investigations number 2.
That covered it. Srinivas, shall we take, go on to the next talk and you take the question for that?
Just one quick question. Dr. Sai, as you said that monotherapy in one of your case examples, you showed that the juxtafoveal lesion, right? And you showed that as a monotherapy. But again, while ending, you concluded in your slide where the steroids have to be started in juxtapapillary and juxtafoveal lesions. What school of thought I read was in any where there is a papillary or perifoveal or parafoveal or juxtafoveal, steroids should be included in those things. Now, I'm a little bit confused with these things. So can anyone just clarify?
Yeah, definitely. Yeah. If the choroidal tubercular granuloma is over the disc, steroid is extremely important, because if we have reactivation, immediately the patient will go for both CRAO and CRVO. In one day, patient will become no PL. So if the granuloma is over the disc, steroid is extremely important in the dose of 60 milligram. We have even given Decadron injection 3 days because we don't want to have occluded vessels because of optic nerve swelling. As you rightly mentioned, juxtapapillary and juxtafoveal definitely need steroids.
I have given intravenous methylprednisolone in the juxtafoveal, juxtapapillary lesions, and then combined with the ATT therapy. Even there's MAN2 quantiferon and TB gold test is positive. This is indicated to save the fovea or disc.
Good.